think Dr. Deverly also is here, so I would like to start the session. So from today, experts from each country will provide us with knowledge related to nuclear medicine. And as the first session, our experts from Philippines will give us a lecture on nuclear cardiology. And on behalf of Professor Dong-Soo Lee, I'd like to introduce today's moderator, Professor Jerry Obaldo. Dr. Obaldo is currently a staff member in Department of Nuclear Medicine, Philippine Heart Center in Quezon City. Dr. Obaldo has accumulated outstanding achievements in the research of nuclear cardiology, and moreover, he has devoted himself to the development of nuclear medicine in Asia and the education of the next generation of nuclear medicine. So today, Dr. Obaldo will moderate the session and also deliver us a lecture regarding nuclear cardiology. He will show us practical issues in image reading, interpretation, and reporting. So please welcome Dr. Jerry Obaldo. You are muted, Professor Obaldo.
Okay, thank you very much for that. So I'd like to thank the TEIN project for inviting us and including us in the project. No, we are one of the centers that will be involved with the TEIN. So this is the first activity for us, although we have been attending some of the lectures before. For today, we will talk about myocardial perfusion scintigraphy. And I asked one of our younger colleagues, she used to be with us from the Philippine Heart Center, and now she's practicing nuclear medicine in the South. She's Chan Sung Ko Fellow of nuclear medicine and PET in Korea also. So I'm very proud to present Dr. Deverly Tumapon to give a talk on myocardial perfusion scintigraphy protocols. Okay, Dr. Tumapon.
I'll enable my share screen. Can you see my slide?
See your slides.
Okay. Good morning, everyone. Thank you, Dr. Obaldo, for the introduction. So I'll be discussing about what should a patient-centered MPI facility should be. So for the lecture outline, I will be reviewing the basics of radiopharmaceutical, cardiac stress testing, and the imaging protocols. This basic knowledge will enable us to put a center that is patient-centered, catering especially to patients with detection for CAD indication. So in a center that is dedicated for myocardial perfusion scintigraphy, it is composed not only of the patient, but also of the staff of the nuclear medicine facility. So that includes the doctor, the technologist, and of course, your gamma camera. So that is a photo that was taken way back during my residency by Dr. Obaldo. So in the basics of a radionuclide, in the mid-1970s, it was thallium that was first used for scintigraphy. And then in the 1990s, technetium-based radiopharmaceuticals were then introduced. So thallium is a cyclotron-produced radionuclide with a half-life of 73 hours. It is its imaging is using the mercury X-rays that is produced during electron capture from thallium to a stable daughter, mercury, with an abundance of 95%. We use the 69 to 80 keV. So the gamma photons were not used because of only 10% abundance. other than thallium, we also have technetium. For technetium, it is a molybdenum generated uh, generator produced from your molybdenum, and then your technetium decays to a more stable technetium with a half-life of 6 hours. So its gamma energy use, the photon energy, is ideal for imaging, which is 140 keV, and the abundance is also ideal at 89%. So that is, thallium is a monovalent cation with a myocardial localization of around 3 to 5%. And your technetium can be labeled with the cold kits like sesamib, tetraphosphine, tiburoxime, and the investigational drug that is NOAT, which is also a neutral lipophilic compound. So with the percentage of myocardial localization as indicated. So the one that is locally available and the one that we have experience with is thallium chloride and technetium 99M sesamib. For the comparison between thallium and technetium, thallium, because of its high total body absorbed dose of around 0.68 rods as compared to your technetium, we only administer around 3 MCI of thallium. So with a low administered dose, it results in a poor count rate. So that is one of the reasons why thallium radiopharmaceutical results in a poor image quality as compared to your technetium. So other than that, we have a low photon energy emissions of around 69 to 83 keV, which is not suited for modern gamma cameras. And also, this is not ideal for the photon energy of 200 keV. Also, there is a lack of a distinct photo peak, and its high scatter fraction further contributes to suboptimal image quality. But then again, we cannot discount the use of thallium-201 because it has its role in CAD detection, particularly with the viability studies. So upon injection, your thallium is readily taken up by your myocytes by virtue of your sodium-potassium ATPase. So since thallium chloride acts as a potassium analog, so it is taken up by your sodium-potassium ATPase pump, and then it is delivered inside your myocyte, and it represents the membrane integrity and cation influx. While your technetium, same with sesamib and tetraphosphine, it is passively taken up by your myocytes because it is a neutral lipophilic compound. So it just passively diffuses and it localizes and it is retained in your mitochondria by virtue of the electrochemical gradient. So again, I've mentioned about the poor image quality produced by your thallium-201, but because of its redistribution properties, it is very essential in one of the applications for a myocardial perfusion scintigraphy. So we take advantage of the redistribution properties of your thallium-201. So upon injection of your thallium-201, the initial uptake as determined by your myocardial blood flow and then also by the integrity of your cell membrane in the myocytes, it is taken up and then at 3 hours, it gradually clears from the myocyte. So as you can see, upon injection in the area of a normal myocyte, there is a gradual clearance from the time of injection up to the 3 hours. So up to 3 hours, if it is just what you call this one, it's normally perfused due to viable cells, there will be no decrease in photon or your tracer uptake. But in the case of ischemia, there is delayed and reduced uptake of your thallium. And in time, it only just equalizes with your normal myocyte. So that is why there is an improvement at a later time. So that is the principle of redistribution. Because in severely hypoperfused but viable myocardium, it takes time for it to uptake the radiopharmaceutical that is delivered. So taking now the ideal characteristics of radiopharmaceuticals for myocardial perfusion, what we want is a perfusion tracer that has a linear uptake with high flow rates. So ideally, the uptake should be increasing with high flow rates, but thallium and technetium sesame D and tetrafosmine doesn't represent that characteristics, because at high flow rates, there is underestimation of their uptake. So these radiopharmaceuticals are not actually perfect, but because of availability in the locality, we still use them because, of course, they have their advantages also. So for the ideal characteristic of radiopharmaceutical, the uptake should be directly or linear with the blood flow. It should have a high pass tracer extraction, a high target to background ratio, and there should be good retention of photon influx for optimal imaging. So as you can see, the thallium has an 88% extraction, which is basically higher from the technetium radiopharmaceuticals that we have. In close percentage is your tiboroxime, which is around 90% or more than 90%. But then again, the high fraction extraction is also coupled with a rapid washout. So it is not ideal for imaging also because of the imaging time that is limited. And the other radiopharmaceuticals fairly has a lower extraction fraction at around 50 to 60%. So now we have discussed about the radiopharmaceutical. We also have to review on the basics of the physiology, because MPI is also a non-invasive physiologic imaging of our myocardium. So we have to take into consideration what happens when there is ischemia. So the image on your right is a vessel that is diagram of a non-obstructed vessel. So your P is your proximal vessel. Your R1 is actually your large epicardial vessels that is exemplified by your LAD, LCX, and RCA. And then your R2 are the downstream coronary coronary arteriolar resistance vessels. And then the R3 are actually the ones that we see in the subendocardial level already. And the resistance comes in at around the ventricular chamber contraction. So in case when there is stenosis, there is vasodilation at the area of your R2 or those downstream arteriolar resistance vessels. So that will compensate with the increase in blood flow, which is limited by stenosis. So even at 80 to 90%, still, as you can see in the image after the R3, that is what we call as a diagram for like a myocardial perfusion slice, like for example, cross-sectional image. So we can see at the short axis that there is actually no perfusion defect that we can see. But if we apply stress, may it be exercise or due to a pharmacologic administration resulting into a vasodilatory effect, now we can see that because of the maximal vasodilation brought about by the stenosed artery, it is already exhausted and cannot furthermore vasodilate. So now we can see the disparity with the effect of the stenosis. So there can now be a reflection of a decreased tracer uptake. So we apply stress because even at 50 to 70% stenosis, we can now detect areas of ischemia. So there are two types of stress that we can have the patient undergo. We can have ideally the patient undergo treadmill exercise. So with exercise, it actually increases cardiac workload and oxygen demand. So the patient may undergo a graded treadmill exercise, the one that we use is Bruce protocol or the modified Bruce protocol. So as you can see, it is graded because other than the speed that is increased, the inclination of your treadmill is also elevated. So for those patients who are not really inclined into exercise or have difficulty somehow performing the exercise, we can use the modified Bruce protocol. It has the same speed with your standard Bruce protocol, but the inclination is not that direct and it is just gradual as the exercise continues. So this can be applicable to patients who are elderly or for those that have difficulty in performing the treadmill exercise. So why do we want treadmill exercise? This is the ideal stressor because it reflects true ischemia. Ischemia is when there is insufficient supply as to the required demand of your myocytes. So adequacy of your exercise is judged by cardiac work as indicated by heart rate and blood pressure, but also measures like rate pressure product, METs duration, and METs and the duration of exercise are also necessary to quantify if the exercise or the cardiac workload is enough that is experienced by the patient before we inject the radiopharmaceutical. Again, we use a more than 85% of the predicted maximum heart rate, that is 220 minus age, as a measure of adequacy of the exercise that is attained. Now, who are those patients that cannot undergo exercise stress testing? So the ones that you see are those with unstable angina, those with heart failure, uncontrolled hypertension, cardiac arrhythmias, aortic stenosis, PE, myocarditis, aortic dissection, severe pulmonary hypertension, and those with acute MI of less than 4 days. So we will not subject these patients, and we will use other forms of stressor. So the relative contraindication is for those not necessarily patients with left main coronary artery stenosis may not warrant exercise. Also those with severe aortic stenosis, arrhythmia, AV block, electrolyte imbalance. Of course, those who cannot follow instruction, we better have the patient undergo a pharmacologic stress. And of course, those with complete left bundle branch block, pacemaker, and WPW syndrome should prefer a pharmacologic vasodilator stress test. So why do we the patients with complete left bundle branch block undergo pharmacologic instead of the exercise? Because of the asynchronous contraction in the septal area, there is a false positive finding or a falsely area of decreased tracer uptake in the septum. So this will hinder us in a good interpretation. So as you can see, this is a patient who initially had a treadmill exercise. He is a patient referred for the detection of CAD because of the risk factors like hypertension and diabetes. So the patient initially had treadmill exercise, but then in the middle of the exercise, he developed a complete left bundle branch blocks. But then again, we still continued, and then with follow up, since we noted the patient to have CLBB already, we have the patient undergo dipyridamole, and we just account for the septum. Maybe at that time it wasn't a true defect, but maybe artifactual in nature. For us to have that not sure diagnosis, it's better to have the patient undergo a pharmacologic stress. In these cases, it is easier to detect because in treadmill exercise, we hook the patient into an ECG. So before we conclude, before we start with the treadmill exercise, we get a resting ECG. So that's it. And the indication for the early termination of exercise, if the patient wishes to stop, then we have to stop the procedure. Maybe he's not really feeling well and cannot really push through with the exercise, then we have to terminate the test. So if there are ST segment depressions, changes in the ECG, and of course in the blood pressure, monitoring the if it's really very high, and if the patient has arrhythmias already, But then again, if we achieve more than 85% of the age predicted maximum heart rate, do we stop already if the patient is able to proceed? No, continue, because we have to be symptom limited. And after the injection of the radiopharmaceutical at peak exercise, we have to continue at least for 1 minute to make sure that the radiopharmaceutical is really distributed. So now we proceed with the pharmacologic stress testing. So we're okay with the exercise stress test, but then again, not all are really good candidates for pharmacologic stress testing. So for those patients who have to undergo the pharmacologic stress test, we have vasodilators that we can use. We have dipyridamole, adenosine, and regadenoson. So your adenosine is actually the one that is endogenously produced in the coronary endothelial cells. So it actually results into vasodilation upon attaching to A2A receptors. So the action of your dipyridamole is just, it inhibits the reuptake of your adenosine. So it indirectly increases the concentration of adenosine. And your regadenoson is similar to adenosine, but it is more specific or has a higher affinity for A2A receptors. So with vasodilation, there is increase in arteriolar resistance, thereby increasing the myocardial blood flow. This looks simple, but in reality, the image is like this. So as you can see, it's not only that we have the A2A receptors on the intravascular in the intravascular vessel. We also have A1, A3, and A2A, of course. So with the attachment of your adenosine in the A1 receptor, it can result to AV block. What we want is the vasodilation at A2A, but also it can also attach to A3. So this leads to bronchospasm. Knowing these receptors, we can now have an idea, or we should be knowledgeable on what are the drugs that may interfere or may compete with the action of our adenosine. So with that, we have to stop caffeine, because methylxanthine and caffeine also attaches to A2A receptors. So with that, we have to stop them for 24 hours. And of course, if we want the patient to undergo exercise, we still have to ask them to stop intake of caffeine, just in case we will convert from exercise to a pharmacologic stress test. And methylxanthine, so caffeine includes coffee, tea, chocolate, so we have to stop them. And also, knowing the effects of bronchospasm and AV block, now we have to select those patients who may be presenting these symptoms that we may want to consider other form of exercise, or we may have to be careful during the stress procedure. So other than with the adenosine, how do we administer? So we need an infusion pump for this one. At 140 micrograms per kilogram per minute is the rate for 6 minutes. This adenosine also only have a half-life of 10 seconds. So we inject for a duration of 6 minutes. On the third minute, we inject the radiopharm, and then 3 minutes after injection, now we image the patient. In the event of a symptom that is presented by the patient and we have to terminate the adenosine infusion, it is enough already to stop the effect of adenosine because of its very short half-life. And then next, we have regadenoson. So with regadenoson, we inject at 0.4 microgram per ml for 20 seconds. And then we flush with saline, and then the 10 to 20 seconds after injection, we with regadenoson, we inject a radiopharmaceutical, and then we image at around 20 seconds for the stress imaging part. And with dipyridamole, this is the one that we have experienced locally. So we inject at a rate of 0.56 milligram per kilogram over 4 minutes. And then after 4 minutes from the time of dipyridamole injection, we inject the radiopharmaceutical, may it be thallium or technetium. And then 3 to 5 minutes thereafter, we now image the patient if it's with thallium. Again, with dipyridamole, it has a longer half-life, so we have to inject aminophylline if we have to terminate the side effects, the symptoms, like, for example, vasodilatory effects. Usually, patients experience flushing, others may have headache, others may complain of chest pain, but with chest pain, we have to confer with the cardiologist who is around all the time when we do the pharmacologic or the exercise stress test if there are ECG changes. So also we can do dobutamine, which is a synthetic catecholamine that increases the cardiac workload. So it has an infusion of incremental rate just to achieve 85% of the maximum heart rate. The one that is the limiting factor for the use of dobutamine is because of its side effect, mainly chest pain and then also with arrhythmia. And even before reaching the desired target, patients doesn't like to continue already, mostly because of the side effect. So among these pharmacologic vasodilator, the one that will really dictate the use in your facility mainly is the price, no? So in 2016, the price of dipyridamole is around $6 times 10. With adenosine, regadenosone is much more expensive at around $200, and also with dobutamine. So you might want to consider those factors in your area. And now after the stress part, we now go to the imaging protocols. So we have different imaging protocols depending on the radiopharmaceutical that you use. So with your technetium, we can do a 1 day or a 2 day protocol. So we prefer to use what we usually do in the facility to have the patient's convenience also is we do a 1 day protocol. So we do inject first at rest and then another injection at stress. So when we do this protocol, the rest stress 1 day protocol with technetium, ideally if we do the rest part first, we have a truly rested patient. And with that, we can also have to take note of the difference in the radioactivity that we inject to avoid crosstalk. So the first radiopharmaceutical should be 1:3 lower with the subsequent injection radioactivity. So it should be higher with the stress part. So we inject the radiopharmaceutical technetium, like we have to wait for around 60 minutes the most, just to clear for the hepatic and the gastrointestinal uptake because of their mode of excretion. So we inject twice because remember with technetium, we don't have the redistribution properties. And also we can inject the stress on a later, like 2 hours after, and then we perform either pharmacologic or the dipyridamole, and then we review the image and then we do the interpretation. So that's with 1 day protocol. Now with the 2 day protocol, the advantage will be maximizing the injected radioactivity. So with the 1 day protocol, we only use 10 MCI for your rest dose, and with your stress dose is around 30 MCI. But if you do a 2 day protocol, you can inject 30 MCI on the rest, and then the stress image, which can be done the following day, will also have a 30 MCI radioactivity. So this is ideal for like obese patients that we want to have a lower attenuation or soft tissue uptake or interference. So that's it with your technetium protocol. So these are the example images of a 1 day protocol with technetium. So as you can see, we have a normal myocardial perfusion reading in here. So as you can see also, there is uptake in the area of near the inferior wall because of the hepatobiliary and the GI clearance of your sesame B. So that is also one of the limitations. It's actually harder for us to perform the sesame B because of this soft extracardiac uptake. So what we can do to eliminate or somehow reduce this artifact is to have the patient ingest fatty meal or have them intake of water just to facilitate peristalsis. Or we can also do prone imaging. But we have to take note, since the half-life of technetium is just 6 hours, we have to be very careful with the remaining activity for the second or for the next stress imaging that we do. So with the 2-day protocol, you can inject around 30 MCI stress and then 30 MCI at rest. Now, can this be a case of express MIBI, which is also one of the recommended protocol for technetium? So yes, this can be a good candidate of an express MIBI. So with an express MIBI, we can perform the stress first and then have the patient undergo the imaging. If it's normal, then we can forego with the resting image. So that is also an advantage of doing the express MIBI. But then again, there are criteria for a normal MIBI imaging. So for stress only imaging, there should be normal stress perfusion scan, provided that the following criteria are met. So there's no hypoperfusion in the myocardium, the LV cavity is normal, the EF is more than 50, thickening and wall motion is normal, and no RV uptake, and there should be no ischemic ECG changes or high risk stress findings during the stress test part. And now we go with thallium. So thallium, we only inject once, and then we take advantage of the redistribution properties of thallium. So we only inject 3 MCI, and then we wait for 3 hours for the redistribution scan. So we can also have the patient go back for the following day if there is still incomplete reversibility of the perfusion defects. So this is an example of a thallium-201 stress redistribution scan. If it's normal, then the patient doesn't have to come back the following day. And usually these are indicated for patients with CAD or high risk for CAD, but that we want to take advantage of the redistribution properties if we find hypoperfused areas. So ideally, one of the recommended also is to re-inject thallium-201 the following day before we image for the 24-hour scan. So half the dose of your injected radiopharmaceutical at around 1.5 MCI. Then we just to increase the thallium blood pool to increase the sensitivity of possible improvement of your uptake. And we can also isotope. This is actually also convenient if we don't want to prolong the procedure. We can do the thallium-201 rest part, and then we can inject the sestamib for the stress imaging. Now we just have to be very careful since we have a dual isotope in here. The different uptake for thallium and technetium we also have to consider when we do the interpretation. And for the other than the protocols, the radiopharmaceutical that we have to consider, you can also try to do a reconstruction as we did before. We tried to reprocess the traditionally the reconstruction parameter that we had was FBP, and when we tried OSEM, somehow it gave us a better picture. And you can also want to try this in your facility if it's not directly OSEM already. So you just have to follow the manufacturer recommendation or the vendor recommendation for the number of subsets and iterations. As you can see, there is a lesser background activity and a good edge detection projection that we have. That is with technetium, and we also do the thallium-201. So, but with newer gamma cameras, most of the reconstruction parameters are already the OSEM. So other parameter that we can also do if we have a if you have a facility that can afford to have a dedicated cardiac, then it is also better if you can have that one, especially if you have a high volume of MPI patients, because number one, it lessens the acquisition time, and you can also do the half dose protocol, which actually results in a good image somehow. So The one that we have an experience is with GE, the Discovery and M530C. It has with a new dedicated gamma camera. They have CZT crystals as opposed to the thallium sodium iodide crystal that we have with the older gamma cameras, and also difference in the collimation, because this one with GE, they use a static multi-pinhole collimation just to increase the sensitivity. So this is the full dose 5-minute acquisition that we had. And when we tried the half dose, the picture is actually also very good, no? So that's it. To end this lecture, in summary, a patient-centered MPI is actually a personalized MPI with the aim of maximizing diagnostic accuracy, which is still based on the clinical indication and with strict adherence to ALARA, of course. Thank you.
Okay, thank you, Dr. Tumapon, for that. After a lecture on how to do the scan, the next talk which I will be giving is on how to interpret. Okay, Dr. Tumapon, can you unshare first?
Patients को भेज ये बस एक
Okay.
प्रोसेस वजन चाहिए कि वो इतने दिन से ये स्टार्ट है कल गया गया तो देखना काम से मतलब एक चीज बाकी चीजों को आप प्रायोरिटाइज कर देना अगर क्लिनिकल है और
Okay, can we proceed? We will entertain the questions after the second talk. Okay, so good morning, everyone. I will be talking on interpretation of myocardial perfusion SPECT, PERS, and pitfalls. And during the talk, there will be these icons, no? Lighted bulb for PERS and danger sign or do not enter for pitfalls. Okay, at the end of the talk, hopefully the audience will have a more systematic and comprehensive approach to interpreting our gated SPECT CT attenuation corrected myocardial perfusion scans. And we will be including all the quantitative parameters that probably we do not mind so much. Okay. So I'll be pointing out common pitfalls also and in interpretation, so this can be avoided. And I'll give some alternative concepts in myocardial perfusion interpretation that might be against conventional wisdom, but I'll give you the reasons also. So there's nothing to disclose. So before one interprets a myocardial perfusion scan, you should review the clinical data. So the first talk was on a patient-centered approach. So it's important to know the clinical data. No? First of all, you determine why was the scan requested. So in most parts of the world, it's usually for coronary artery disease diagnosis. And for those patients who have known CAD already, it's for the extent of ischemia, significance of the coronary stenosis, to determine which is the critical lesion, if there are multiple lesions. Also for prognostication and re-stratification. Here in the Philippines, we do a lot of myocardial viability assessment. In fact, in our centers, almost half the scans are done for this indication. That's why we still use a lot of thallium here, as you can probably guess from Dr. Tumapon's talk. Okay, so again, because of the patient-centered approach, you want to know if the protocol done was actually suitable for this particular patient. And most importantly, you want to answer the clinical question in the scan report. So when viewing the gated myocardial perfusion scan, of course, the workstation is preferable over printouts. First, you want to review the acquisition for patient motion and for attenuation, like here. No? I don't know if you can see the left breast shadow falling over the heart. Patient motion also can be reviewed here. This is a sinogram, and if the patient moves, then there's a break in the sinogram. Okay, so these are what patient motion can do. No, some artifacts you can actually produce severe defects in the scan. The so-called hurricane sign here in the image on the left is produced because two halves of the scan are not aligned, no, like here. Okay, so you have to recognize this before you start reading the scan, because if this cannot be fixed, then probably the scan must be repeated. You do not have to interpret it anymore. So there is patient correction software, and hopefully you can fix it like as shown here in the right side images. Okay, so the most important probably in the scan reading is describing the location and severity of perfusion defects. So this came out in 2002, and hopefully by this time, everybody is using the 17-segment model. The 17-segment model for the heart, for the LV, is used not only for nuclear cardiology, but in all, no? Including CT, MRI, ultrasound. So there are standard names for all this. Hopefully everybody will be using this. So you have the basal segments, mid and apical segments, as well as the apical segment. Okay, so these 17 segments have been distributed roughly according to the three main coronary arteries. But what I'd like to tell you is that, of course, this is not completely accurate. No? For instance, the LAD can extend up to here in segments 3 to 9. The RCA can extend also to segments 2 to 8 and to segments 11 and 5, and so on. No? The left circumflex also can extend to the inferior wall, segments 4, 10, and 15. But with that said, some patterns may help you localize even further, including the left anterior descending artery branches. No? For instance, if the lesion is in segments 1, 7, and 13, these are probably the diagonal branches of the LAD. And if the lesion is in the anteroseptal segment, then it's probably septal perforator branches. Okay, the left circumflex also, segment 6, the basal anterolateral segment is probably quite specific for left circumflex. If this is missing, then probably you don't have a left circumflex lesion. Okay, after localizing, then you want to describe the severity. So there are five levels of severity, from normal, mild, moderate, severe, and absent uptake. A scoring system was introduced. We'll talk about this because we're not very fond of it, no? And I'll tell you why. So 0 for normal, 1, 2, 3, 4 for absent uptake. And visually, these are probably the best examples I can find. So this is normal. This one is a mild defect here in the inferior and inferoseptal, moderate defect in the inferior, severe in the inferior and inferoseptal, and absent uptake here in the apical. This is how the American Society of Nuclear Cardiology describes it quantitatively. Okay, as you can see, severe and absent uptake, there is some overlap, no? And we will talk about this some more. So the American Society recommends that scoring system be made. And in fact, there are many centers here in our country that follow this strictly, no, or routinely. These are the centers that are influenced very much by those who probably trained in the USA. So there's a mild defect here, basal anterior and anteroseptal. Then you have moderate defects in the other anteroseptal segments and the apex. If you add all of those, the score is 12. No? So you can do that for the stress images. We call that the sum stress score. And if you do it for the rest, that's called the sum rest score. And if you get the difference, then that's the sum difference score. Okay, like here, you can ask the computer to do it, but you have to be careful, no? So you have some stress score here, some rest score here, then some difference score here. So 13, 0, minus 0 equals 13. But if, as you can see, the computer quantitation can be faulty because there is a severe defect actually in the basal inferior segment, and including the basal inferoseptal segment. But look, the quantitation says it is normal, no? So you have to be careful of that. Now, if you're not sure how severe the defect is, then you can use the 10-step color scale. For instance, this is particularly important for myocardial viability assessment, where you want to quantify if there is at least 50% tracer uptake in that segment. So here, you're not sure, is this severe or absent already? Then you can use the 10 color step. So it is clearer that this part here, the green, this is 40 to 50%, and that's the probably bottom line of the viable myocardium. So it's much easier to score it if you use the 10-step color scale. Okay, so starting why we don't do this routinely. Some stress score, what does it mean? It's a combination, very important. It's a combination of the severity and extent of ischemia or infarct. The sum rest score demonstrates myocardial scar or segments supplied by severely stenotic coronary arteries, at least 90% stenosis. Okay, the sum difference, of course, is the ischemic but viable myocardium, or some use the term ischemic burden. Okay, the scoring system became quite popular because of a series of publications in the late 1990s, mainly from the Cedars-Sinai group. So this is one example. No? As you can see, this is event rate. Black is myocardial infarct and white is death. As you can see, the more severe the score, the higher the event rate. In fact, it's almost linear correlation. That's why this became quite popular. But again, the pitfall here, actually, these papers use a 20-segment scoring system. So you have to adjust, or you cannot use these values by themselves, because by this time, most centers are using the 17-segment model now. For instance, if I tell you that the score of the patient is 7, it's not intuitive, you know, unless you're familiar with the scoring system, then the score of 7 does not mean anything. You know? That's why there is such a thing as adjusted scores. And these scores are adjusted by dividing the score by 68, no? Then multiplying by 100 to get the percentage. 68 comes from the 17 segments and multiplied by 4, which is the maximum score. So 68 is the maximum score for the 17-segment model. And by doing that, now you get, instead of SSS, you get some stress percent. This also reflects a combination of severity and extent, The same for some breast percent and some difference extent. No? So they mean the same thing, except that the value you give is already in percent. For instance, a score of 7 might not be very meaningful to most people, but 7 divided by 68 is around 10%. So 10% is much more meaningful to most people. Okay, what are the pitfalls of using the sum segment score? This is why we don't use it in my centers. We're not very fond of it. I'll tell you the pitfalls. The pitfalls are in general 3, no, at least. Since these are quantitative, classification criteria should be strictly followed. That's the first one. Second, should we even sum the scores? And third, what does the sum stress score represent? Okay, we'll talk about those 3 in the next few slides. Okay, since these are quantitative, then as much as possible, the criteria should be strict. It's the American Society of Nuclear Cardiology criteria, which I showed earlier, and compare that with the European, 2009 guidelines, and you can see immediately that the numbers are very different, Okay, not only are the numbers different, but they refer to very different things. For instance, the American guideline numbers actually speaks of a percentage reduction from a normal segment. The European, however, this is based on the segmental activity of a reference population, meaning this is done using a digital database. So you need the computer to be able to do this. That's why they refer to 2 different things. The European guideline is 2009, and a newer one came out in 2015, and they did not include this anymore. So they just left it to the individual center how to quantitate defect severity. Okay, so it became subjective, meaning the scoring system is not really that rigorous. Okay, the second issue that we have is, can you even add the scores? If you ask a mathematician, they will tell you, no, you should not be adding these things, no? Because, okay, here is the severity description. Then you have the score, 0, 1, 2, 3, 4. These are ordinal data. In fact, you can call it A, B, C, D, E if you like, no? And of course, you cannot add A, B, C, D, E. But we add 0, 1, 2, 3, 4 routinely as if it makes sense when actually it does not. Okay, for instance, since some stress score is ordinal, a score of 2 is normal by definition. A score of 4 is abnormal, but it is not 2 times worse than a score of 2. No? The concept simply is not there. So even though it is 2 times 2, it doesn't make mathematical sense. And that's why people ask, you should not be adding all these things. Okay, the third is, what do SSS or SS percent represent? Is it extent or severity? Like I said earlier, it's actually a combination of both. So in fact, even the experts are confused. No? Look, here in this paper, they call it normalized SSS, which is the mathematical definition, but it doesn't say what it represents clinically. Then from the same group, they call it percentage of total myocardial involved, which is for me meaning extent. Okay, for this author, it is percent severity. Okay. So another author, it is percent myocardial abnormality also, which for me means extent. And probably the most accurate mathematical definition is this one, visually quantified total perfusion deficit. And this one, severity weighted estimate of total defect size. So size is extent, but it is severity weighted. So it's really a combination. Even the societies give contradictory terms. The This one from the European guidelines described it as score, normalized to percent LB, which is correct mathematically but doesn't mean much clinically. So from it is stress, perfusion, extend. Very clear, it's extend. What they call it when actually it's not. It's a combination. So in the second guideline, this time they call it percent myocardium abnormal. So again, from the European guidelines, you should describe extent as small or large, which is correct, no? And it must be included in the scan report. Severity is described as mild or severe, so meaning they are completely different things, and they should be included separately. However, look at this. This is optional, no? So it's a should. They say extent should be quantified in SSS, but severity is also quantified in SSS, so it's really confusing. That is why we don't bother with this, no? We just describe it as mild, severe, small, and large. Okay, here is the issue. This is an example where the sum stress score is 6 in both of these cases, and 6 divided by 68 is around 8.8%. So here, the score of 6 is spread out over the inferior and the interoceptal segments in the apex, and this is described in the scan as a large mild defect. And in the case on the right, it's also an SSS of 6, but this time it's a small severe defect involving the apex and the inferior wall. These are actually quite common cases. The case on the right may even be construed as normal, believe it or not, because there are only 2 segments, and sometimes there is a prominent apical slit which extends to the apical inferior segment. So which is worse? We think that the large mild defect is worse prognosis-wise. Okay, from the latest guidelines, a consistent approach to defect severity and extent are clinically important because these contain independent prognostic information, meaning they should be separate, no? So as causes as combines, they're not separate. Okay, which is worse, extent or severity? From an old paper, extent is definitely the single most important prognostic predictor of myocardial events. Okay. As Nick describes the extent, 1 to 2 segments, medium 3 to 4, large 5 at least. Alternatively, and this is actually in we divide the number of abnormal segments by 7 and get the percent LB extent visually instead of using some stress score and so on. Okay, artifacts. Probably the most common artifact using conventional SPECT is this one, inferior wall defect in males because of the diaphragmatic attenuation. We take the scans in the supine view, so this is a stress study. To severe defects in the inferior segments, although the patient has no disease. In this same patient, we took a stress bone acquisition, and as you can see, the severe defect in the inferior wall using conventional imaging completely disappears. It's almost normal now. So you can see the difference. This is severe, and this is basically normal. A prone image was taken. Unfortunately, the prone imaging is not very comfortable. And if you have an expensive machine, the extra view also, extra acquisition also will has a cost attended to it. So state of the art right now is SPECT CT. So this is conventional SPECT, and this is SPECT CT on the right. As you can see, the moderate to severe defect in the inferior wall inferior segments disappears almost completely, no? Even though both are taken in the supine view. Okay, so again, here is the SPECT conventional. This is a normal study. And if you do SPECT CT attenuation correction, look at the inferior wall, then there is an overcorrection, no? Which you must recognize. Not only is there an the apical segments become thinner, which is probably more realistic because the segments near the apex are very thin. They're just 2 to 3 millimeters, I think, compared to the rest of the LV, which is around 10 millimeters. So you have a thinning of the apex normally here when you do CT attenuation correction. So you must recognize this. Some will actually read this as a mild defect already, when actually this is what a normal study looks like, and it's probably more realistic. We got used to this because we've been doing SPECT for a long time, and we got used to this when actually we know that the apical segments are much thinner than the rest of the left ventricle. Okay, extracardiac activity was mentioned by Dr. Tumapon earlier, and CT attenuation correction will tend to exaggerate it, like here, in the inferior wall in this right side of images. You still have to be careful because you can have misregistration, like the SPECT image has moved laterals in the lateral segments, like here. So if you align it properly, then the defects disappear. So this is an artifact. I gave this talk, similar talk to this in 2018, and I had to use a published case, but with our new machine, somehow this became much more common. So in fact, just the past couple of months, it was not difficult to look for a case in my own center. Look at this, the SPECT has moved anteriorly, and as a result, look at this, there are severe defects in the anterior segments because of CT misregistration. So this is something that you have to look at and be careful about, because this is an artifact produced by the CT attenuation correction proper. So the bane of nuclear medicine, they say, is attenuation in the inferior wall in men and anterior wall in women, inferior wall in men and anterior wall in women. And therefore, one of the most important advantages in myocardial perfusion SPECT is CT attenuation correction. But it requires relearning to interpret properly. No? The images are different and artifacts may occur. So you still need to read the uncorrected SPECT images. So now you have to look at 2 sets of images. Okay, the next artifact we'll talk about is shine through using the 1-day rest stress sesame protocol. So this is the first injection at rest. And here is an image in the second injection at stress. No? So you see development of a moderate to severe defect in the inferior segment. Now, if your count ratio is only 1:1, then look at this. The inferior defect almost disappears. No? It looks almost normal now. And this is what it looks like with the 5:1 count ratio. Then you have a severe defect here. What does this mean? This means that you must have at least 5 times as much counts in the second injection, no? To avoid the shine through protocol, shine through artifact. So how do you avoid shine through artifact? The ASNIC guideline says you must have 3 times at least activity in the second injection compared to the first. Otherwise, you will have the shine through artifact. But don't forget that there is a coronary flow rate difference, no, between stress and rest. After stress, there is at least 2 times increase in coronary flow, and therefore 2 times as much tracer will be deposited in the myocardium after stress. So shine through when you're using the stress then rest protocol will still happen, because if you do the stress first and inject, let's say, 10 millicuries and compare it with the rest where you inject 30 millicuries, then the difference actually will be just 2:3, no? In which case you will have a shine through artifact still. So the rest then stress protocol is really preferred. So you do the rest first with around 10 millicuries, then you do stress using 30 millicuries, and you will have a 6:1 count ratio. So this will avoid shine through artifact. So that is something that you will have to take into account. Rest then stress is completely different from stress then rest. Extracardiac activity is very common, especially with sestamibi. And there are 2 effects. No? The ramp filter artifact will result in a reduction in segmental activity very near the extracardiac activity. So as Dr. Tumapon earlier mentioned, you can try iterative reconstruction, and it will look a lot better. No? But it is also possible for extracardiac activity to result to an increase in uptake because of scattering, like the case I showed earlier, where the CT attenuation correction actually increased extraordinarily segmental uptake in areas where there is extracardiac activity, and this is because of scatter. Okay, one disadvantage of myocardial perfusion scintigraphy is that there is underestimation of the extent of CAD. And this is because SPECT shows relative regional perfusion only, meaning the best perfused regions may look normal. For instance, this is a case of a 3-vessel disease CAD patient. But if you look at the lateral segments, it looks normal, no? So the LCX appears spared when actually there's also stenosis of the LCX. And this is because SPECT normalizes the image, and the best perfused segments will therefore look normal. And probably the extreme effect of underestimation of ischemia is this one, balanced ischemia in patients with 3-vessel coronary artery disease. It's actually not very common. In fact, it's hard for us to collect a case, no? But here's one example, no? 62-year-old female with angiographic 3-vessel disease, and the scan, if you look at it, immediately looks normal. And probably the only indication that there's something going on is after stress, the LV ejection fraction goes down, no, instead of up. And this is probably because of post-ischemic dysfunction. And if you look very closely, you might see, is there transient ischemic dilatation? No? I think so, no? If you look at this slice here, it's slightly bigger than the rest image. So those are the only indications that there is really ischemia going on. So this is one of the few cases of balanced ischemia. It's not very common. So if you are interpreting many studies where you say possibility of balanced ischemia, then probably we're overdiagnosing balanced ischemia, no? Because it's very unusual actually. Okay, so left bundle branch block was already mentioned earlier. you will have a artifact in the septal segments. Okay, how do you recognize artifacts? First of all, if the defect is located in segments where attenuation artifacts are common, and you have to be aware of this, no? So most probably it is an artifact. So anterior wall in women and the inferior wall in men. Then also, when you have a non-coronary distribution of defects, for instance, basal anterior, inferior, or septal segment defects, if you think about it, a coronary artery disease, stenosis, where you will produce only solitary defects in the basal segment. So most probably this is non-coronary. And also slit-like defect in the anteroseptal segments, which I'll show you in a while. And also, if there is normal wall motion and thickening, then you should probably think that, oh, it's probably an artifact. No? And of course, if the ECG is normal, then that's another additional sign that probably the defect is also an artifact. Okay, so this is an example of a non-coronary distribution of the defects. If you look at these segments, I don't know if you can see my mouse pointer. So there's a moderate defect here, which improves at rest, mild defect, which improves at rest. Actually, this is due to the fact that the rest images are slightly bigger. No, this is something we see very commonly. This is in all the major brands and in many different centers, but I don't know why it is not mentioned in the books. You can see that the rest image is slightly bigger, and because of this, it looks like the basal segments are improving when actually they're not. No? So this is just an art. And another common artifact here is this one, slit-like defect in the anteroseptal segments, which some authors say is due to the insertion of the right ventricle. No? I don't know if that's even true. Okay, let's talk about left ventricular wall kinetics now. So that's, we just finished the location and severity of defects. Now let's go to wall kinetics. So you should also assess wall motion and thickening, LV volumes and LVEF, because these are some of the most important cardiac parameters. And the modern myocardial perfusion scan not only has data on perfusion, but also on LV wall function. Ischemia is a better predictor of ischemic events in the future, no? Such as non-fatal MI, unstable angina, and revascularization. No? But ejection fraction predicts cardiac death better. No? This is a conventional wisdom from long ago, and I just used one particular publication. But we know this since the 1990s. Okay, you want to assess wall motion using grayscale because it's very difficult to look at the motion when the color is changing. No? However, you assess thickening using color, and this is because of the partial volume effect, where actually things are not thickening, but rather there is just a change in intensity. Okay, because of the low resolution of gated SPECT and because of the so-called partial volume effect, because myocardial thickness is almost the same as the resolution of SPECT, which is around 1 centimeter. And in fact, near the apex, the myocardial thickness is even much lesser than that. No? So wall thickening is perceived as an increase in intensity rather than an increase in thickness. Okay, and an increase in intensity is more accurately seen in color than in monochrome. No? Because in monochrome, of course, you just see shades of gray and so on. While in color, it can be a change from, say, red to blue, which is much easier to see. Even though we say in the report that there is wall thickening, actually it's just an increase in intensity. No? Yeah, this is physics, so it's more of an optical illusion actually. So this is a case of a normal ejection fraction of around 60%. And you can see that here it becomes brighter up and systole. And I put double-headed arrows which are the same length, no? Just to show you that there is really no increase in myocardial thickness, even if we say in the report that there is thickening. Actually, there is just an increase in intensity, and this is because of the partial volume effect. Okay, so very common case, ejection fraction that is very high. Here is a case where it is 87%. And some of my colleagues all over the world, they solve this problem by saying that, you know, ejection fraction is more than 80%, because beyond that, it should be a hyperdynamic heart. But for me, that does not solve the problem, because essentially you're still saying that the ejection fraction was more than 80% when actually it's probably just 70 or 65%. Okay, this is the artifact where LV ejection fraction is very high, is seen when the heart is on the small side. No? So we see it in women, we see it where the LV size measured by SPECT is less than 60 ml usually. And this is because, again, of the low resolution of SPECT, the partial volume effect, and scatter from the thickening myocardial wall. And because of all this, the LV and systolic volume becomes very low. That is why, now if you're familiar with the formula for ejection fraction, then it will result to a very high ejection fraction. So you have other quantitative parameters like here, this is volume and filling, no? So in our country, this is usually done with echo. And if you're going to do it with SPECT, which we don't do routinely, then you should use the 16 frames per second quantitation. Probably give a higher activity of technician maybe when you're going to do this. Okay, you can also use the phase histogram. This is normal, and this is the image inferiorly is in a case where there is desynchronization. Okay. Also, this is phase analysis. The image on the left is normal, while the case on the right is for left bundle branch block. And you can see the spread and asynchronous contraction of the heart with left bundle branch block. Okay, don't forget to assess the RV. The right ventricle should be barely visible normally, but here on the left, we have a case of pulmonary hypertension where the right ventricle is quite clearly seen. And the case on the right is an exaggerated right ventricle because this is a case of tetralogy of Fallot. Okay, for viability assessment, depending on which author you read, then tracer uptake can range from 40 to 50%, no, of normal uptake indicates viable myocardium. Below that, then there is no viable myocardium, and revascularization will probably not help. No, and this is regardless of the tracer use, whether it is sestamide, thallium, BMI, PP, ammonia, or even FDG. No, so these values hold. Okay, transient ischemic dilatation is one of the findings of severe coronary artery disease. And from the name transient ischemic dilatation, there must be ischemia. No? If you don't have ischemia, then there's probably not transient ischemic dilatation. TID value is quantitated also. This is very high and it's very apparent, no? At stress, you have a dilated heart which decreases to almost normal. But global TID value may not be elevated because most TID is actually involving only the apex. And here is one example. TID of 1.19 is still borderline. No, that's almost normal actually. But visually, look at this. No, you have quite apparent transient ischemic dilatation, but only towards the apex. That's why the value may not be as abnormal as you want. Okay, this is conventional wisdom. The signs of severe and or extensive coronary artery disease when you have large severe defects, when you have involvement of more than one coronary artery, you have severely depressed wall function with an ejection fraction of maybe less than 35%. When you have transient ischemic dilatation, and when you're using thallium, there is increased post-stress lung thallium uptake. If you have these, which you put in the report, by the way, then probably the patient will benefit from revascularization rather than medical therapy. Okay, let's talk about some other quantitative parameters before we finish. You might not be using this when actually this comes with the most software already. You know? So extent here is different from SSS. This is actual extent because the value 25% means 25% of the pixels in the heart is abnormal. No? Instead of the 17 segment model, which we look at visually, when you do computer quantitation using QPS, then there are around 500 pixels, I think, for the LV. So it is much finer. No? Total perfusion deficit is 17%. This is like SSS. Here is the graph. This is a very popular graph. So this is the extent. This is just the number of pixels that are abnormal. But when you include defect severity, then that is called total perfusion deficit. Okay, the final quantitation that I'll talk about is LV shape. When you have chronic volume overload, then eventually you will have spherical remodeling. Okay, and also very importantly, with ischemic heart disease, you have remodeling and becomes from an ellipse, the left ventricle becomes more spherical or rounder. Okay, so these are actually available with the SPECT software that is probably available in your machine. So you have stent, you have extent, you have total perfusion deficit, and you have shape parameters. No? SI is shape index, and you have eccentricity index also. So let's talk about the shape index first. This is two-dimensional. It's just talking about the diameter here divided by the length of the LV using the endocardial surface. And normally, it should be less than 0.54 published value. And as the LV dilates spherically or undergoes spherical remodeling, then the shape index value goes up. Okay, the other index is the eccentricity index. It's a bit more complicated because this is three-dimensional. Okay, the computer tries to fit in a sphere or spheroid inside the LV. So normal value should be 0.84 or greater, no? And if the left ventricle undergoes spherical remodeling, then you have a decrease in EI value, like so here. The simplicity index 0.70, which is much lower, 0.84. No? So consider using this, no? Because the shape index and eccentricity index may precede other parameters. For instance, heart failure with preserved ejection fraction is seen only in 50% of congestive heart failure. So even though the ejection fraction is still normal, if your shape indices become abnormal, then the patient may not do well. No? In this study, shape index has predicted value for congestive heart, and the eccentricity index may identify those who respond to cardiac resynchronization therapy. We have a modest experience with this, no? So one of our younger colleagues did a study, and the eccentricity index had a weak positive relationship with the number of coronary events. But if you include the LVEF, then there is some additive power, and it approaches statistical significance. Okay, should we incorporate SI and EI to our reports? Yes, you may, no? But first of all, probably you should determine normal values for your institution, because software are different from machine to machine. And aside from the absolute values, you should also look for change in SI from rest to stress. Okay, if the SI index and the eccentricity index becomes worse after stress, then this is associated with more cardiac events, according to this very recent study, just a few months ago. Okay, so in summary, gated SPECT provides information on perfusion, wall function, and cavity shape. So normal variants and artifacts must be recognized, and I showed you the most common ones. And you have a number of semi-quantitative and quantitative parameters which you can use and include in your reports. Very much for your attention, and we will accept questions now. Thank you.
Thank you for your wonderful lecture. Can I have one question about what might be the difference between if we do the gating and if we get a thickness and motion result? What might be the difference, and what is more relevant result that we should refer to regarding thickness and motion?
Yes, usually both occur in parallel. No? It's quite rare for thickness or motion to be abnormal by themselves. So usually they go together. So you have to consider that motion, there is a tethering effect, meaning the segments adjacent to the abnormal segment may be moving and just pulling the abnormal segment also. So in which case you have to look at thickening in this case. But generally, the abnormalities go together.
And regarding the extracardiac activity, I think we also encounter some problems regarding the extracardiac activity. So although like we do in iterative reconstructions, if there are still some like perfusion visualized decrease, what might be a good way to interpret that kind of how shall we interpret when there is a suspicious of extracardiac activity, like decrease due to extracardiac activity?
You mean artifactual, or is this pathologic?
Yeah. So
like
if we
lung cancer
if it is
or breast?
If it is hard to discriminate between extracardiac artifact due to extracardiac activity or whether it is real pathologic defect, would there be some way to have more confidence in interpretation?
Well, among other things, we look at the conventional SPECT without CT attenuation correction and compare it with the one with CT attenuation correction. And many times you can probably decide if it's real or not. No? If you just look at one set of images, then it's really very difficult. So even though we have attenuation correction now, we still need to look at the set of images without attenuation correction, and it helps. The point really is to avoid as much as possible extracardiac activity. So sometimes we do delayed imaging, we do prone, we give the patient water, all these things. No? Yeah, it's difficult. This is again one of the advantages of thallium. With thallium, you usually have a clean image, unlike with sestamibi, in our experience.
Thank you very much. And lastly, actually, we are using cardiac dedicated CDT SPECT, and we also see some apical like defect or decreased uptake. And would it be also similar effect of a high resolution like CT, as you have mentioned for the CT attenuation correction?
Yes. Oh, well, SPECT is a very low resolution. So we don't really need a very high resolution CT. It will not have any advantage at all. There is a question in the chat. Shatsia, Fatima, yes. We know each other for more than 20 years. What do you think is the best option for CRT patient selection and follow-up? Synchrony parameters or SI-EI? So SI and EI parameters have, there's only one study I found that has some correlation. No? So I think it's still synchrony parameters. The CRT is very expensive. No? I think here in our country, which the patient will have to pay himself, is around $20,000 US. I think something like that. So it's very expensive, and they have a set number of protocols that they follow before to choose patients who will receive this. So at present, SI and EI will not have any additional benefit on top of the protocols that will be used. Okay. May I ask Dr. Tumapon, she's still around, for an obese patient, thankfully it's not very common yet in Asia, what is probably the best protocol for myocardial perfusion scan?
Hello, Doc. Yes, for obese patients, ideally we can do a 2-day protocol with sestamibi. If it's okay for the patient to come back the following day and just explain the implication in the imaging and in the interpretation, then I think they will agree to come back. So we just maximize the activity. We can do the rest stress first, so that if it's normal, then he doesn't have to come back. So you can give the 30 MCI already. Okay, Doc.
Okay, do we have any more questions from the audience?
I'm Ed Kim. Can you hear me well?
Prof. Jerry.
Can you hear me well?
Oh, yes, we can hear you.
Okay.
Dr. Kim?
Yeah, I really enjoy your comprehensive review of myocardial perfusion imagings. And I'd like to ask a couple of questions. First is about the reverse redistribution. We have heard that reverse redistribution for several decades. Some say about possible artifacts, some say maybe some due to collateral, maybe supply of blood. Some say that may be reason for postprandial angina. So what's the current thinking about this reverse redistribution? Have you seen that case?
Yes, we still we still see cases of it. Most of the time, it is probably artifactual because of the smaller activity of the radiopharmaceutical at rest compared to the stress. So whether you use thallium or sestamide, then usually the counts at rest is less. And because of this, most cases, the current thinking now is most cases are artifactual. In which case, with that said, it's still possible to get partial thickness myocardial scar cases where, because of the partial volume effect also, at stress, after stress, when you give your radiopharmaceutical at full dose, then uptake looks good. Then if you use thallium, there is washout, or if you use sestamide, you give a lesser amount, then the lesion becomes more prominent. No? So most of the time it is artifactual, but there are cases where it is actually real. And probably the most significant for me is myocardial partial thickness scar.
All right, thank you. Next is about stunned and hibernating myocardium. Those are not also common, but somehow it should be theoretically quite a common, but how often you see that kind of case?
Yes. Oh, myocardial stunning, we see in practice after stress. So left ventricular ejection fraction goes down. No? Normally, there should be an increase of around 5 percentage points. So from 50 at rest, it should go up to around 55 after stress. But many times, if there is ischemia, then it goes down. So this is an actual everyday occurrence of myocardial stunning, but it is done by it is iatrogenic. No, it happens because of the procedure itself. Now, if you want to become philosophical about things, hibernating myocardium, the original concept really is there is a chronic low flow state, and the LV now matches that chronic low flow state. But current thinking is most cases of hibernating myocardium is probably repeated stunning. So in which case, then there is very little difference. No? Yeah, I don't put hibernating myocardium in my reports. I know many of our colleagues do it, but if you really look at the definition, then it is something pathological and probably should not be used. What we say is viable myocardium, ischemic but viable, and so on, which is more descriptive of what is going on. Because hibernating myocardium itself, the concept is under attack. No, it's not the original one that Rahimdullah mentioned in the 1980s and 90s. No? So things have changed.
Okay, lastly, it's been said that about half of the normal people seems to have a thinning of the apex, myocardial apex. So we expect to see relatively decreased activity on resting and stress images. So how we possibly detect the infarct in that segment?
Yes. You have to get used to it and relearn how to read, especially when you start doing SPECT CT with attenuation correction. Then you'll be surprised. You really have to learn how to read again because they look different. The example I showed earlier is one of the best ones that I can find that really shows the difference between conventional SPECT and SPECT CT. So the SPECT CT, as you can see, reflects reality much better than conventional SPECT because the apex really has much thinner diameter compared to the mid ventricle and the base. So uptake there is, so it's really just getting used to what a normal scan looks like.
Okay, maybe another how you compete with the cardiologist dovuramin myocardial perfusion study with your nuclear sort of myocardial perfusion study.
Okay, maybe Dr. Tumapon can answer that question for the butamin. Then we can go next to Dr. Erwin from Indonesia, I think.
Thank you very much, Professor Jerry Obaldo. Thank you for your enlightenment today. I would like to ask you about ischemic burden. I read in the journal that the calculation of ischemic burden, we can use SSS, SDS, and also TPD. But sometimes I have a problem if we use SDS, if the defect is irreversible. So how to solve this problem if we use SDS to calculate the ischemic burden, Professor Jerry? Thank you.
Yeah, like I said, we're not very fond of this, but we can use it. And personally, I would not use the computer-generated values. No, we would look visually and calculate all these values. If we do it manually or visually, then I have more confidence in it. No? Yeah, it will show ischemic burden.
Okay, jadi you don't use automatically, but in the calculation of ischemic burden, we calculate manually. Is that right?
Yes. Yes.
Okay.
Yeah.
Okay.
And again, if you caught that part in my lecture about the criticisms about this, you know, if you ask a mathematician, you should not even add these values. Some of them will say, no, of course, the clinical studies show that they have clinical value by adding this. But, you know, if you go really high conceptual, the philosophy of it, then, you know, it becomes questionable. Then again, with the same number, they can have very different meanings, like the example I showed where you have two different cases, both with an SSS of 6. No? So all this you consider. And because of all that, that's why we don't do it routinely. A lot of centers here, like I said, especially those who have trained in the USA, they do it routinely. No? They say, oh, the SSS is 30 or something like that.
Okay. How about the TPD?
Then
Can we use TPD for?
hopefully the cardiologists are. Come again? Can you repeat the question?
I'm sorry. How about the TPD, total perfusion deficit? Can we use TPD as similar with ischemic burden?
Yes, it's the same. But TPD is done by computer, no?
Yes, calculated by computer. I think the result is no big difference between TPD and SSS calculation.
Mm-hmm.
Okay, so
Yes,
can we?
it should be similar. Yeah, it's not going to be exactly the same because TPD is 500 pills while SS.
Okay. Okay. Thank you very much, Professor Jerry Obaldo. Thank you.
Okay, so any more questions? I think our time is up. Okay, so we would like to thank Seoul National University for inviting us again.
We are very thankful for your wonderful lecture. And okay, and if there is no more questions or comments, we could end today's session now, and we can meet next week. Okay, thank you very much, and really appreciate
Thank
your
you.
lectures.
Good day, everyone.
Thank you.
Deverly.